right, on that note, we are going to go ahead and start this week's Journal Club. I am Dr. Diane Sanders-Cepeda, and I ask anyone who's not speaking yet to please go on mute. We have a lot of information that we want to go through and share with you. So let's go ahead and jump right in. So I want to start where we normally start, with just a brief update around where we're at. And we know that globally, we're 120 million cases throughout the world, with over 2.6 million deaths. In the United States, we're at over 29.5 million, with 536,922 deaths. When we look at where we're at, where we're tracking around positivity rates, the United States 7-day average has been 8.18%, which means that we're seeing around 57,000 confirmed cases daily. That is a significant decline since we last spoke. So that is a real positive number. And I was very happy to see this morning that our 7-day average in Florida was 5.88%. So still a little bit higher than where the World Health Organization recommends for reopening, but we do know that we have reopened across much of the state. We see some spring break pictures, so we're not going to talk about that, but there is more news about that to come. So hopefully we'll keep seeing positive numbers. I just wanted to highlight this because the COVID tracking project has been giving out some really great data. They have since stopped collecting data and reporting out anything, but as of March 4th, we did see that in the long-term care facilities, although less than 1% of America's population, we're accounting for 34% of those US COVID deaths. So Florida, like I said, we've been seeing some really good things here in our state. I think there's a lot of positive things to talk about when it comes to how we're doing in Florida, spring break aside. We're about 1.9 million plus total cases. But when we look into our daily cases, we have seen a gradual decline. This was updated as of this morning, and is data through the 14th, which was, Sunday? We had on Sunday daily cases of 2,872, and it brought our positivity rate at 6.13%. So that's not bad given everywhere that we've been at. What has been really wonderful has been what we've been seeing in the SNFs and ALFs, with both our positivity rates for our residents and staff continuing to decline. And I think that's a testament not only to the vaccinations, but just to the vigilance that we've had in our SNFs and ALFs. So where does that bring us now? When we're looking at some of the updates, we see that as of this morning, this is what we're looking at for at least one dose of a vaccine. We have over 72 million people in the United States receiving that one dose, over 39 million fully vaccinated. I believe over the weekend, I think it was on Saturday, we had 2.98 million vaccinated in one day. So that's all great news. In Florida, we are seeing that according to the CDC report this morning, there's only over, I think 5 million people vaccinated. It's really good, solid, steady numbers that we're seeing. So that is a good thing. This is a little harder to read, but this is just from the Federal Pharmacy Partnership long-term care data. They had over 7 million receiving the first dose, 2 million receiving the second dose, fully vaccinated, which is good news. And we're going to talk to Kim about some of these things in a minute. I wanted to also just let you know that the CMS has put out updates around nursing home guidance in accordance to the recommendations that the CDC provided. This is also some good news, and it really does go into what to do if you have only greater than 70% fully vaccinated in your building, and how you can go into doing that those visitations, I think the one question that I saw trending this weekend was, how do we, in getting those patients out of the hospital, make sure that they either get their first dose, or when the Johnson & Johnson vaccine is available, get a dose of that prior to coming to our facilities. So we will probably get into those discussions too with Kim in a minute. So I wanted to just also touch upon the fact that there is constant monitoring of the different variants. I know this is like a headline on every news show about how many variants, and I think there are 6 that we're monitoring. The top 3 are listed here, which are the UK, the South African, and the Brazil variants. We also know that there are variants in California. Those variants have been seen in Texas. We are seeing the New York variant, not to the same penetration as the 3 that the CDC is tracking steadily. So there is some information on their website about these. We did talk about this a few weeks ago, and as we get some updates, I will make sure we put those in our library. What I want to do, though, for the remainder of our time is really just do a deep dive into our overall progress. And for this, I'm going to bring on Kim Smoak. And Kim, if you would just introduce yourself, reintroduce yourself. I don't think you need introductions, but this is your second time on our Journal Club, and you've spoken to us 1,000 times, but just to be complete, please go ahead and introduce yourself.
Great. Thank you for allowing me to be here. And I'm glad that Ian put up my shot with me in green, since it is St. Patrick's Day. So I have green on as well in my office. So at least I'm in compliance with St. Patrick's Day attire. I am Kim Smoak. I am the Assistant Deputy Secretary for Health Quality Assurance here at the Agency for Healthcare Administration. I'm the Chief of Field Operations and oversee the, as a State Survey Agency Director, I oversee all the inspections in the healthcare facilities. I work directly for Deputy Secretary Molly McKinstry, who, as you know, has been right at the forefront of leadership at our agency, and honestly throughout the state, frankly, when it comes to the COVID response. So I just wanted to, make that aware as well. And just another reminder for those on the call today, if you don't know, we do have a new secretary here at the Agency for Healthcare Administration. Secretary Simone Marstiller started with us a couple of weeks ago. She hit the ground running because we're in the middle of session, plus still dealing with the vaccine rollout in the state. So thanks again for allowing me to be here with you guys. I really do appreciate this opportunity. So would you like for me to kind of just get started with the conversation about some of the things that you wanted me to talk about today?
Yeah, let's go ahead and dive into what we've learned thus far. I mean, I think that would be a good place to start.
Okay, great. Now, I know you gave a little bit of statistics. I have a little more to share if possible. Just for our hospital COVID cases, just to let you know, there have been a 15% decrease in COVID positive cases in hospitals over the past 2 weeks. So we have seen a slow decline with COVID positive hospitalizations. And since we're like the spring break capital of the world, it seems, I think we all are holding our breath as we get through the next couple of weeks with spring break to see what happens after that. But, as we know, we've seen those decreases, and a 42% decrease in COVID positive residents and staff in our nursing facilities and assisted living facilities in the past 2 weeks. So we're seeing that. I know you showed that data earlier. Since I know some of what we wanted to talk about is vaccine, there have been over 67% of our residents in nursing homes that have received the vaccine. A little over 35% of staff received the vaccine. Obviously, we want the staff a little higher than that and appreciate any outreach that you're doing as a medical director and trying to address vaccine hesitancy. I will say this, every day we are getting more and more feedback from facilities that have said, hey, I've talked to additional residents or talked to additional staff. They want the vaccine, now that, the Johnson & Johnson is out, the one shot and you're done. in addition to the Pfizer and Moderna, we are seeing more and more request in the nursing home industry and assisted living facility industry of more staff wanting to get vaccinated. So that's a good thing. And I think, early on there was a lot of hesitancy with that. And I know a lot of you are working with your facilities, and just encourage you to continue to work with your facilities. I know a lot of nursing homes have put out some great messaging internally. Some of the things I've heard is, the leadership in the facility, when staff see the leadership in the facility getting the vaccine, and they see that your arm doesn't fall off, or you don't start glowing in the middle of the night, or something like that no adverse side effects, then people are more apt to take it. That seeing that leadership take that first step to get that. I have seen that. I have seen some facilities do video clips of residents who have said, please get the vaccine, how that impacts the resident and their quality of life and their ability to have family, come in to visit them. So a little bit of pressure, I think, from the residents. I've seen some of those best practices and just continuing to educate. And I know as medical directors, we actually need you on the front line there, helping with education for vaccine hesitancy. So let's talk about, I did get some questions here. So we'll talk a little bit about those. I have a couple things written down, so I'll put my glasses on to see them. So some of the things, kind of lessons learned, or what were the most significant changes that we believe our long-term care facilities really face. Obviously, big one, we know it was the lack of PPE. That's been a big conversation, I think, recently, is just the amount of PPE that the nursing homes had to purchase and use every day is very different than that you had to use previously. So the lack of PPE, lack of facility knowledge, and the ever-changing CDC recommendations. I think that we all have been caught up in, one day CDC says to do this, the next day they say do that. So, and that was a big thing for us, as getting that information out to providers too, is just trying to keep up day to day. I actually had one staff member, and still do to this day, have one staff member, that's her job every single day, go to CDC website, by midday every day, send out any new updates. What are those new updates? Highlight those new updates. And then that's the best practice that we started right away, because things were changing. So we needed to get information out. I mean, the surveyors are out in the field, so we needed to give them the tools necessary to do their job, and then to share that information with you guys. But those are some of the things, that we see, ongoing changes in guidance, not only from CDC, but CMS. I think that, as the regulatory agency, we were getting something about every week from CMS, a new updated focused infection control form, new guidance, or new, well, we want you to do it this way versus that way. So some of those, as things change, because we know over time, things change with the COVID response, and change with, how we would approach, residents who are COVID and isolating and quarantining those residents. So as they change and new information emerged, making those adjustments and adapting to that various changes. One of the things we felt regulatory wise that were a challenge, maybe some lessons learned, is lack of facilities having those trained infection preventionists. That was in the requirement, and then it was rolled back a little bit. And then bam, the pandemic hit. So lack of having those trained on-site infection preventionists, and staffing challenges as well, having staff working, day in and day out. I know for a lot of nursing home folks that may be on, we know that was a challenge for you, and still is to this day, a challenge as far as staffing. And then that constant battle of education and knowledge of your staff, and obviously visitor restrictions really have impacted or been significant challenges, because we know a lot of facilities really had a lot of family members that came in a lot to help with their loved ones. Maybe came in, and fed mom, three every meal came in, and then now all of a sudden the daughter can't come in to feed mom. So then now the staff are having to adjust to take that additional responsibility on. It's their responsibility anyway, but the family was able to come in to help with some of these care area concerns, or assisting with ADLs. And now all of a sudden, we're on lockdown, right? No visitors can come in. So now I think that increased staffing demands and staffing needs as we went through the pandemic. So some of the things that we still see that remain a challenge for facilities even now, obviously allowing families and visitors to return to the facility and still protecting residents. And I know Dr. Sanders-Cepeda mentioned it, that the new updated visitation guides, a lot more flexibility in those requirements now. They definitely are more stringent than the state. So obviously we would say, hey, this is what you follow as a nursing home. But now looking at those tweaks that CMS made and following those, but it still is a challenge, I know, allowing those visitors and families to return, and still your obligation and responsibility to protect all your residents. We know staffing still remains a challenge for many nursing homes. I hear it every day when we do surveys, obviously, and we're back to doing recertification surveys. We're looking at staffing. That's something that we hear frequently. A large portion of our facilities are still dealing with staffing issues. We are getting feedback. Many staff left healthcare to avoid COVID altogether, right? And staff are not returning to the workforce. So I think that staffing it continues to be a big issue in that workforce. Still, I think managing the guidance that comes out. We know now the PPE supply chain is open, but we also know CDC continues to review and revise their guidance based on new information that emerges over time. So still challenging on making sure you keep up with that. As I mentioned earlier, have one staff person. That's her job every single day. Even now, we're still in the public health emergency. That's not been lifted. So even staying on top of that is still something that's a challenge. Can
I ask you,
sure.
Going back to one of the points that you covered about the staffing challenges, I think the first thing that I did see when that guidance came out was a lot of medical directors' concerns on how they were going to be able to accommodate visitations. Do you know of any best practices or any facilities that their approach to that, like where that may be the golden example of what we should be doing?
No, that's a great question. And no, I don't. I've not heard anything from any one facility over another. Obviously, I've had some discussions with both nursing home associations and, as they give guidance to their members. One of the things, we're looking at it and balancing the DEM order 20-011 is still in place, that the state visitation requirements. And then we have the CMS memo. So we're still working through some of those differences and nuances and having some conversations with providers. But that is a great question. I do not know what facilities are doing as far as their best practice. I think really, even when CMS released the memo, we've had some conversations with CMS leadership, and they were, really, I think we all were a little concerned about some of the language that they put in about, if your county positivity rate is less than 10%, less than 70%, more than 70% of your residents have been vaccinated, how all that plays. Facilities are really going to have to pay attention. And almost on a day-to-day basis, frankly. Maybe as you guys are hearing from your facilities or working with your facilities, maybe sharing some best practices amongst each other would be good too. But I haven't heard anything yet. If we do, obviously that will be something we can have further discussion on.
Thank you.
Sure, absolutely. One of the other things that you guys have asked that we talk about is facilities that were designated as COVID units early in the pandemic. What were what were their experiences? We had 23 facilities. 5 of those facilities were full facilities were designated as COVID positive facilities, and the remaining had, a wing or a unit or a floor that was designated. And I think, getting them set up was a little bit of a challenge, and I think that's some lessons learned as us as the agency, kind of looking back how we would do things maybe a little differently. And some things we would do differently is it was really driven by Medicaid and health quality assurance. Us as the regulatory body, we came in from a regulatory perspective of, as we were going through lists of facilities, really looking to see that facility, that individual facility's regulatory history, and have we recently been in there? If we've not recently been in there, going in to do a focused infection control survey before an agreement was signed. For these 23 facilities that we designated, it was nonstop for them, and it really was. And we actually had a say in making referrals to facilities. Examples would be hospitals would reach out to me directly and say, "Hey, Kim, we have two COVID positive residents. They came from ABC nursing home. They're not able to take them back. Are there any beds available in the designated facilities?" And so I'd work with those designated facilities in those areas, reach out to the administrator or corporate official, and then work on that transfer. In that, I was very heavily involved in that. And the facilities, they obviously, if they were agency designated COVID facilities, they did have to look at the admission to see not only, they can manage the resident being COVID positive, but what we did see is some hospitals want to make referrals to our nursing homes or COVID positive nursing homes that were beyond the capability of what a nursing home should be taking. And that's something, that we had to work through. And those are kind of lessons learned. And we just tried to keep providing education to hospitals that, hey, you can't just throw any old person into a nursing home. Doesn't work that way. They still have to be able to meet their needs. And there was just a learning curve with that, I would say. What was a challenge and lesson learned for us. As I mentioned, a lot of these contracts were actually Medicaid based. They did get an enhanced Medicaid rate. Medicaid really was the driver, working in concert with myself and actually Deputy Secretary Molly McKinstry. And obviously that was under the leadership of Secretary Mary Mayhew when she was here, and support from Governor DeSantis. And we really think that was we believe, I'm sure there are critics that really helped us, early on to really, try to get a handle on it. The facilities that were designated, we did make sure that they had adequate PPE supplies. We worked directly with Department of Emergency Management to make sure that they had the PPE needs. Not only, that we went in, as we know over time, when CMS changed requirements for us regulatory wise to go in to do the focused infection control surveys, our 23 designated facilities, I think that we got to a point, the height of the pandemic, we were probably going in every week to do a focused infection control survey, in addition to our Department of Health going in. And we just felt that we needed that strong regulatory, oversight. Did we identify some problems every now and then? Absolutely. But they were fixed. It was deficient practice. They fixed it and we moved on. But we, those were some things I think that we learned. And the wind down period, as we were, ending those contracts in August and September, some of our lessons learned from that is maybe, a couple of facilities, it took a lot longer. Obviously, our facilities that were fully designated took a lot longer, but really looking at that and how we would do those if we had to. I hope we don't have to, but if we had to do those in the future. I will say, as you know, during the holidays, December, November, December, January, when we were looking at some increase in cases, we did have a discussion with a couple of the facilities that were designated, early on during the pandemic about, reopening their wing or unit, if we needed to go that route. Because we were concerned about as cases were increasing, we were just holding on, hoping that facility that we wouldn't have to do that, and luckily we didn't. But one thing that really helped, I will say, is a lot of facilities learned over time, you know, educated themselves, worked with our county health departments, worked with the HAI program, and really started to feel more comfortable taking care of COVID positive residents. And I've seen a lot more facilities over the past, 3-6 months, so to speak, really create their own designated area for their COVID positive residents. They may not be accepting residents from the hospitals or the community, so to speak, but if they have residents that are COVID positive, instead of sending them to the hospital or reaching out to a sister facility and say, hey, I have this COVID positive resident, I can't take care of them. They really have set up their own wings and units internally to accept them. So I think that's really kind of they just learned over time, maybe feel a little more comfortable. I think when everything first started in Florida, obviously everybody was very nervous. There was a lot of information that was emerging over time was a little bit scary, I think, for facilities. But as they learned and felt more comfortable, then they started developing their wings and units. So,
Kim, can I ask,
sure,
for those facilities, and we know all of our facilities, they have that designated area. What are resources or financial relief resources available to those facilities who are trying to care for a COVID patient? I think we know that they could cost a lot more than the average patient. So is there another relief mechanism, given that that designation is over?
No, our agency is not providing an additional, funding for that. Like I said, during the height of the pandemic, when we had the agency designated 23 COVID positive facilities, there was a Medicaid rate enhancement, but there is no rate enhancement now. So, yeah. And the 23, I think one of the other questions was, what's their current status? As I mentioned, several of our 23 COVID positives facilities, they still have some form of, a wing or a unit that they still maintain. And as things were spiking during the holidays, I did reach out to a few of those. They did work with us a little bit on taking some residents in from hospitals, because we were getting some frantic calls from hospitals about, nursing home and ALF residents being there and really didn't need hospital level of care. But we do not have any designated facilities right now. But facilities can, like I said, set up their wings and units, and we do reach out periodically if there's an issue, and we kind of do a case by case if we need to. So that's and I will say some about our COVID positive facilities. Word got out around the nation that we did that, and I received a lot of phone calls from my counterparts in other states asking questions about us setting that up. Evidently their state leadership wanted to know more about it, so they reached out to me. We kind of talked with them through it. I shared information with them, and I think some states eventually started doing what we did. I don't know how many, but I do know that I'd had a lot of facilities spoke to that. A lot of states that reached out to me. So that's our COVID, our COVID units, kind of how all that's working. And I don't know if any of the medical directors that are on, if facilities that you are medical directors of, if they have COVID wings or units, but that is, obviously we are still seeing that out there. And moving into, I guess, some of the vaccine questions that we had. Most facilities that have had their third vaccine clinic, absolutely. Through their long-term care pharmacy partnership through that Walgreens and CVS. And CDC gave guidance on how they, continue to receive the vaccine. Any insight I have on facilities getting vaccine right now, Obviously, yes. Some of the things, if nursing homes are saying, hey, I got more residents and staff, you can reach out to me. I am working with CDR Health has been contracted with Department of Emergency Management, and they went through and did the bulk of the assisted living facilities. They are handling adult family care homes now. They've done independent living. That's not part of us, a CCRC, just regular independent living. We do not regulate independent living, but they worked with those. They're also have been doing some HUD facilities, and then there's some of the state pods that are out there. Obviously, like for your staff members, they can go to one of the state pods that, they're for FEMA sites out there. They can go to those, bring your work ID, you're a healthcare worker. You meet within that, you are in compliance with the governor's executive order for getting the vaccine. If you're a healthcare worker, we do have a website, and hopefully everybody has that. It's myvaccine.florida.gov. And if you have, like I said, staff members can go to that website and sign up and go to one of the pods. Or if there are facilities, like I said, I just had a couple of facilities this past couple of days that, based on some outreach we had to the facilities, said, hey, I have like 10 more residents that say they want to be vaccinated now, and a handful of staff. And so I've been communicating to CDR Health to get that arranged. But obviously, if you're trying to get it done very quickly, going to one of the sites. But if you have residents, absolutely, you can share that to get that information to us. But we are reaching out to facilities as well and obtaining that information.
Yeah, so. And I will add that I know on the CDC guidance, they talk about the 3 avenues that facilities could go through, and we recently see some updates from AMDA, who's our parent organization. But talking to your long-term care pharmacies, seeing if they'll become a provider, that's definitely a good route, and make it a plan.
Absolutely. And one thing, to be a vaccinator in Florida, you have to be enrolled in Florida shots. Mm-hmm. So that's an important too. And I think just about as far as I know or am aware of, the long-term care pharmacies, our community pharmacies that a lot of you use, they are already enrolled in shots, because they're other vaccines that they've been given all these years. So they're already enrolled in shots. So that's a good thing. We've been, that is something we continue to push and work with, that, this needs to be a point where, we're not in the allocation business anymore, so to speak, that you just do it normal day to day. And so, getting to that, we're moving in that direction, not at that point fully yet, but I think everybody knows that's the direction we're moving in. Just wait until it all pans out. So yeah, thank you for asking all those. How many, and I think I mentioned the percentage of folks that have been vaccinated, the long-term care residents that have been vaccinated. I can just mention those again. 67% of our residents have been vaccinated. A little over 35% of staff have been vaccinated. And as you know, some of our emergency status questions, I know everybody hates going in and updating that every single day. But we are capturing residents and staff members, the numbers of staff and residents that do want vaccines. So that's helping us to do a little outreach and getting more current information from facilities and contact information, so that we can pass that along to CDR Health to hopefully, arrange some additional clinics and facilities.
Kim, may I ask, because I think I asked earlier if you needed our clinicians, medical directors, our organization as a whole to help, where are we seeing the majority of that vaccine hesitancy? Is it by county, by area in Florida, or is it just sort of dispersed throughout the state?
I think it's a little bit, dispersed throughout the state. I think, we have seen a little more vaccine hesitancy in our South Florida area, maybe some rural areas. But just, I think it's just keep on educating folks on the vaccine. And I have seen a lot of, I will say this, we offered the vaccine to my staff. They're in that category of healthcare worker. They're not providing hands-on care, but they're going in and out of facilities. And I do have over 61% of my surveyors have been vaccinated, just like you guys. I mean, I can't make it mandatory. I know employment wise, as a private industry, you can make it mandatory for your staff. We're a state agency. We cannot make it mandatory. We can highly encourage it, and I do encourage it. And my managers are encouraging it every single conversation they have to. So we're doing the same thing. We're educating our staff on why are you hesitant to take this? I have, just like some of you may have some of your folks may have some current medical issues that they're trying to, get resolved. So we're dealing with a little bit of that. Some of them they don't want to get vaccinated at all, but trying to, just like you, continue with that education. But absolutely, I will ask my offices if they're getting any strong, feedback from some facilities locally, and that's something maybe I can share with Ian as I get it, of what the biggest, kind of what some of the hesitancy that we're seeing out there when we're going in and out of facilities, and pass that along.
Yeah, because I think we're willing to get on a Zoom call, go to the facility, do whatever we need to do to help out, and get on our soapbox and preach a little bit about why we want you to take this.
Yeah, absolutely. I think sometimes some of those peer pressures may work too, from if my friend got it and she's fine, I may get it, or even some of the residents that if a resident has a favorite staff member and they were like, I got mine, please get yours, because it's really gonna, I want my family to come in, and you getting vaccinated is gonna help us move that along. I think like I said, we are seeing that. I don't know how that's working, but we are still seeing some of that.
Good.
Yeah.
Can I ask a question?
Sure.
Can I ask a question? Kim, this is Marty Getz. As a rule, your staff being offered opportunity to be tested when they go into facilities, as a courtesy, just the antigen tests?
Mm-hmm.
I mean, do you know if that's occurring?
I do know, well, just to let everybody know, there is no current state or federal requirement that surveyors have to be tested or vaccinated. It's up to the individual states. We early on were very aggressive, and that's something that I really pushed for early on for my staff to have the opportunity to get tested, and we did. So we were on that every 2 weeks testing, like early on when the requirements came out, before CMS came out with their requirements, we were getting our staff tested about every 2 weeks. As I mentioned, over 61% of my folks are now vaccinated too. Some still continue with testing. Although I can't make it mandatory, you are right, Marty. Some facilities have, when we go into a facility, they will ask the surveyor about being tested. And they will say, I know some facilities say, well, we can offer you the antigen test. And some of my staff are like, yeah, great, go ahead. I appreciate it. Then that means I don't have to go get tested at the county health department. Some, do flat out refuse. And there is no requirement for them to do that. Obviously that you're right, that it would be a courtesy, but I do hear that is happening out there.
Yeah, I mean, your staff go into every room and literally touch every resident in these facilities. Our intention, our plan is to offer everyone that shows up, and we're in our survey window.
Yeah,
I already know that. Is to offer everybody that shows up a rapid test, an antigen test as a courtesy, or not, but to offer it.
Yeah, absolutely. Like I said, I have seen many facilities do that. I've gotten calls from my offices saying the surveyor called and said that the facility wanted to give them test them before they went in. I said, if the surveyor is fine with that, then absolutely, please do it. I know that's something we definitely encourage and support. I can't make it mandatory, but obviously I support it 100%.
Yeah. Okay, thank you.
Absolutely.
So Kim, I wanted to just make sure we touch upon a few more questions. And one is really about how should facilities stay prepared? You know, you mentioned holding your breath around spring break. You know, what do you think? What do we need to do to stay prepared?
I think that now's not a time. I mean, just because people are getting vaccinated, and now's not a time to let your guard down. And obviously, we are encouraging the visitation, especially with the relaxation of some visitation requirements. I think it's a time families come back in, but now's not the time to let your guard down. I think that we still need to continue to push mask wearing. I have a mask right here in my office, but I'm in my office by myself. When I go to another part of our complex in another room, I wear my mask. Continuing to encourage hand hygiene. I think that's very important. I think also continuing with donning and doffing PPE appropriately, making sure staff are wearing appropriate PPE. We have still heard, actually just last week, we were in an assisted living facility and they were still reusing masks. Now we know that their supply chains are open. I think that there's no need to reuse your mask. So, continuing to adhere to those infection prevention and control. And I think those are things CMS are pushing. Dr. Scott Rifke's our Surgeon General. He keeps, saying the same thing. I have an opportunity to see him frequently and have conversations with him. He continues to push that message. Facilities are still going to have to stay on top of just the basics, just the basics, infection prevention and control. Continuing to screen your employees when they come in, and continuing to offer employees, if you don't feel good, we tell that to our surveyors. If you wake up and you don't feel good, don't even get in your car to go anywhere. Call your supervisor immediately. Let them know you don't feel good. You'll be taken off the schedule. Doesn't matter. I'll blow a time frame before I have an employee of mine not feeling good going into a facility. And I think you guys need, facilities need to use that same, message. If, don't, people should not come to work sick. Gone are those days when we get up and have a runny nose or coughing or whatever, and I don't feel good, but I'm gonna work through it. Gone are those days. I think that facilities are going to have to really, and I know that is a stress factor when it comes to your staff, but I think these are some things that we're going to have to really pay attention to. And I think as medical directors, you pushing those messages, I think are going to be very strong. I mean, you medical directors, I really see, you really need to be very actively engaged and involved with the nursing homes. You're the educators, you're subject matter experts. We listen to our physicians, right? So, no matter we think we know, I mean, especially now, I think that having that medical director involved in those conversations, starting now, I imagine, as I think we all, that there'll be CMS regulatory changes, at some point. I don't know what's coming, but I think we all know, based on all the inquiries, all the audits that we're getting, all the data that CMS is looking at, and our legislative branches, whether it's state or federal, are looking at as far as what changes. And I think that we need to be prepared for any changes that come, but we got to stay vigilant. I mean, we can't just say, oh, yep, I got vaccinated, I'm done. I think we do still need to stay on top of it.
Yeah, speaking to that very point, I know that there's renewed calls to have the names of medical directors published alongside of the nursing home administrator and the director of nursing. What is ACA's feel like? What is your opinion or insight about that? If you don't want to share the opinion, just curious.
Well, I can tell you, as a state survey agency director, I absolutely agree. I think that the medical director's name should be there. The facility, is required for the regulatory requirements to have a medical director. If you look at Florida's, our Florida Health Finder, and most of you administrators on the call, Marty Getz knows, if you look up his facility, his name is listed, and it's his name is right there. I understand it'll be removed at some point, but his name is there as the administrator. The financial officer is listed. So I'm not, I think for our state, we are a big push for transparency. I cannot speak for the secretary of our agency, but I can speak for my role as the state director. Whoever's that medical director, it should be out there. It should be known.
And there's also a push. I know recently California submitted, there was legislation submitted to have those medical directors of nursing facilities be certified medical directors, which is a board certification. And there are other states that have this, but Florida does it. What do you think about that as far as your recommendations?
I think that's probably the future. I think that and publication of medical directors' names are part of the future. I think that certification of the medical director, I think that was in one of those, in that early report, what was it? We released in September, that commission on COVID, that was an early report that, CMS had or HHS, Department of Health and Human Services, had a, industry leaders, stakeholders, advocates, that, did like a work group. And I think that was one of their recommendations, to push for certification of a medical director. I don't see, why I think that's a good thing. I think that goes a long way to, and obviously I think having the medical directors behind that, I think it gives it a lot more leverage. And I think it just shows that as a medical director, you're very serious about your role. You're very supportive of what you need to do in our nursing facilities.
Diane?
Yes, Dr. Kaplan.
Yeah, just make mention, Kim. Hi, Dr. Kaplan.
Hey, Dr. Kaplan.
Hey, just as an FYI, okay, a year ago at AMDA, Florida sponsored, you may be aware of it, a resolution just to that effect, to mandate minimum training for medical directors serving in that role. So we have at least a national, our parent organization backing. And I think we really need to rekindle that, starting with, people such as FHCA, Leading Age, et cetera, et cetera.
Absolutely. Thank you, Dr. Kaplan. It's great to see you.
Same here. The other tiny thing I wanted to add, Diane, apropos to public listing, Kim, I assume you would be okay with just the name of the medical director in the same way the administrator and the facility are listed, without a mandatory listing of private contact information.
Oh, absolutely. Yeah. I think there's a push in this day and age for more transparency, but I think there needs to be some control over that transparency. But I would agree with you, Dr. Kaplan, just a name, just like the administrator's name, or financial, officer's name. Absolutely.
Thanks.
Thank you.
I take it, Kaplan, that you don't want everybody knowing your cell phone, which is fine.
Only yourself, Diane, okay? Try to keep it.
Yeah.
I'll give out all the cell phones, not to worry.
Yeah. Well, I got a lot of people have given out my cell phone number. I get people calling me from all over asking me.
So yeah, Diane, from an official standpoint, let me follow up on my thought on that.
Sure.
I actually think there should be 2 tiers of public listing. I think the hospitals, DCF, surveyors, official medically related agencies in any way, shape, or form, I have no problem if they have my personal contact info. I don't think my personal info should be put out in the yellow pages, etc. I have no problem with the facilities number, obviously. People can get a hold of me as medical director whenever they want, if they want to. My name's listed, it's on the board in the facility lobby, etc. But I do think there should be tiered listing. One tier for people who, like Sunday night, 8 p.m., ER physician really has an issue, COVID-related issue or whatever with my building, they should be able to get a hold of me. And I have no problem with them having my personal contact info. Thanks.
Absolutely. And Dr. Cepeda, I do have a couple of other comments, if I can, about, staying prepared. And some of my staff sent me a couple of notes, and I would be remiss if I didn't mention a few things is making sure, and we all know it's coming, the additional, the full-time coverage by that qualified infection preventionist. And I think I mentioned that earlier, and making sure that facilities still have their adequate supplies of PPE. We mentioned about, staying on top of those recommendations, and providing staff ongoing training on infection prevention and control. Don't let your guards down, now. And I think it's going to require administrators, directors of other nursing leadership in the facility, infection preventionists, even the medical director, doing rounds within the facility, observing, just like when we come in to do a survey, we're observing. If you look at our reports, a majority of where we gather our information from is through observation. So facilities need to follow that same process. That's what we're seeing. We're watching staff don and doff PPE. We're watching them, use hand hygiene or not use hand hygiene between patients. So those are some of the things I think that we need to still stay on top of. And I know that we have had a lot of conversations about COVID and infection prevention and control. I do want to take a few minutes to also mention there are other things that we are seeing out there that are grave concern in our facilities as well. We are still seeing concerns with CPR, a resident being full code, facilities not knowing the code status and, performing CPR, or, again, issues with advanced directives in general. We have seen a big increase of elopements in our nursing homes, very serious elopements, residents getting out and being found miles and miles, down busy streets, down honestly I-4, and being gone for hours. We've had a situation where a resident left a facility, walked to their house, where they used to live, and facility not knowing where they were. We are seeing issues related to care and services, residents falling out of bed with fractures, the staff just not paying attention, essentially not following their plan of care. So while we have COVID and we're still in the public health emergency, we have seen a uptick in our immediate jeopardies that we have seen out there. I will say from October the 1st through the end of February, we have seen a huge, almost a double from previous years related to infection, related to immediate jeopardies. Yeah, we still have the occasional immediate jeopardy related to failure to clean or follow manufacturer's recommendations of glucometer between resident use. But some of the more concerning findings we have recently with immediate jeopardy have been, CPR, elopement, just basic, care and services not being provided. So I just wanted to pass that along as well, because you as medical directors, you do play you should be involved when that is happening in your facilities. And if we do have an IJ situation in a facility and you as a medical director are not aware, that obviously is a problem that the administrator should be communicating. Even something that it may not be related to the medical director, but you still need to be involved, especially with advanced directives. You need to be involved, in those and working with facilities. And I'm not sure when we do have an immediate jeopardy situation, we're working with a facility, I'm not sure the medical director is really pulled in. Obviously, we like to have our interviews with the medical director or the pharmacist, depending on what it is. But I just wanted to make sure that I had an opportunity to mention that, because we are seeing some serious issues out there, and I'd be remiss if I didn't point that out too. So.
I thank you for that. That is very helpful, and I'm glad you shared that with us. If anyone has any questions for Kim, we still have a few minutes.
Diane, I'm sorry to take time, okay, but I do have a question that I put in the chat box. So Kim, a specific scenario, patient who was going to be admitted for rehab from acute hospital setting, was hospitalized for a totally non-COVID related diagnosis. Let's just say UTI with sepsis, is fully vaccinated and COVID negative, okay, within 24 hours of transfer or upon potential transfer. Do they still need to be quarantined, as many facilities have been doing with all transfers from the hospital, for 14 days?
You know what? I think that, and I believe that, and I don't have it in my office. I think I remember reading something. CDC changed that recommendation. There's no requirement for them to be quarantined.
Right, but some of the facilities like mine within our corporate structure are still doing that. So I'm trying to at least get some backing to not have to do that. And I point to the current regs, okay?
Yeah, continue. Thank you, Dr. Kaplan. And I answer that period. I mean, we talk about that periodically with Florida Healthcare and Leading Age. Go back to current CDC. And obviously we don't want people to be isolated or in quarantine unnecessarily.
Right.
That really impacts their psychosocial functioning. So no, you're right, given the CDC. And I want to say Dr. Rivke's our Surgeon General. I think many of you may have talked to him over time. He's addressed that on a couple of our calls, and maybe the next nursing home call we have, which I think is the 1st of April, we can readdress that. But we follow the CDC recommendations.
Yeah.
Thanks.
Yeah.
Kim, it's Marty again. By the way, we are not quarantining new admissions. We are getting the testing status prior to admission here.
Sure.
Kim, how is your staff probing the advanced directive? How are they probing that? What do they do to probe that?
Well, a lot of what we're finding, Marty, frankly, is some self-reports that through, facility reported incidents or the state adverse incidents, they're coming to us through those self-reports. And then we would just investigate it. I mean, what do you mean like probing?
So for example, during a survey with your staff to a nursing assistant and ask if they know the code status on the resident she's caring for?
We really would ask more about, the advanced directives. It wouldn't be that we would just generally go around and poll CNAs onto, the code status of your resident. Obviously, when there's a concern as part of our investigation, we would ask if they were informed as to what the code status was. But I mean, CMS really modified some of their requirements a couple of years ago to really focus on that advanced care planning, which would be part of that advanced directives.
Yeah. Okay.
Sure.
So I want to thank everyone. Thank you, Kim, for giving us such a thorough update on everything. Thank you so much. And if you have any questions, please email us so that we can get those questions back to Kim. And everyone have a great day. We'll talk to you in 2 weeks.
Thank you very much. Appreciate the opportunity.
Thanks, Kim. Take care.
You.